Okay.
Hello and welcome everyone.
Now,
Hello everyone and warm welcome to everyone. I am Dina Redinger and this is my co-host Sharon Weinstein. We are co-authors of the book Think Differently: 18 Strategies to Fix Broken Thinking. We invite you to engage with us and your peers as we address issues related to nurses and in the workforce. Our studies of those with leadership positions. We also found that there is success happens when we ask the right questions, but we solve the right problem. Our prospective healthcare writing careers make us uniquely qualified for this role as facilitators. We invite you to be a part of this program today. And just to remind you, this is our last program. So we are very excited to bring a very special guest. We've conducted these on Tuesdays and Thursdays over the first quarter of this year, and we found amazing results and information and very key, interesting ideas, but more importantly, stories about how to make things better. Our goal was to provide these nurses the opportunity to express their opinions and to share their ideas. Before we start, we want to acknowledge you. We want to thank you. We want you to put into the chat where you're from and who you are. And we want you to engage with us as we ask questions of this amazing guest. And I'm going to allow my co-host, Sharon Weinstein, to introduce our guest for today.
hi, and thank you. Thank you for that, Dina. Today, we welcome Dr. Katie Boston Leary, the Director of Nursing Programs at the American Nurses Association, overseeing nursing practice and work environment, and Healthy Nurse, Healthy Nation. That alone tells you that you need to be here. She has specialized in and is certified in perioperative nursing, nursing administration, and executive leadership. She is a John Maxwell trained speaker and coach and is also adjunct faculty at the University of Maryland School of Nursing, teaching doctoral level nursing leadership courses, and adjunct faculty at Francis Payne Bolton School of Nursing at Case Western Reserve University. She was recently the System Chief Nursing Officer at the University of Maryland Capital Region Health in Maryland and was elected and served as the president of the Maryland Organization of Nurse Leaders. She was previously the Senior Vice President and Chief Nursing Officer at Union Hospital of Cecil County in Maryland for 5 years. Katie led her team at Union to their second ANCC Pathway to Excellence designation and to win the coveted annual ANCC Pathway to Excellence Award in 2017. If that's not enough, she has strong partnerships with deans and chairs of nursing programs in the communities in which she's worked and beyond. She has developed many nurse leaders, from charge nurses to executives, and she's been invited to Capitol Hill in Washington, D.C., with the American Organization of Nurse Leaders to discuss the havocs of regulatory burden on hospitals. To me, regulatory burden on hospitals translates into regulatory burden on our profession. So welcome, Katie. We are so glad that you're with us today.
Yes. Thank you, Sharon, and thank you, Dina. I really appreciate being on your show. I've been seeing a lot of your other episodes with other amazing guests, so it's truly an honor to be here.
Thank you. Go ahead, Dina. Do you want to start us off?
Well, you recently presented to the ACHE Congress with the Quint Studer on care delivery models with a packed room, and we've just got to hear more about this. You've got me intrigued. Tell me about that.
Sure. That's definitely going to get me warmed up because I was so excited about this. So we knew I had connected with Quinn Studer at a couple of other conferences that he's had, and he's always been intrigued by the data that I bring from the American Nurses Foundation. So he was curious about, how do we get to some action on innovating care delivery models? And through our conversation, we decided that we needed to deconstruct the term, understand some of the elements of care delivery and redesign, and look at that differently, but also get feedback from nurses and nurse leaders separately to understand whether there's a gap that exists between what nurse leaders believe will work or is working and what nurses that are actually caring for patients feel is working. So that was pretty much the design of our study. And we were able to unveil the results of that study at ACHE to a packed room, which we were very excited about, and shared a lot of different things. One, the big overriding issue is that there is a gap, unfortunately, between nurse leaders and nurses in terms of what is needed, or even perceptions around being able to look at certain roles differently. For example, LPNs, which is a hot topic right now. A lot of organizations are adding LPNs to their care delivery teams. Leaders have an impression, particularly in the acute care setting, that this is a very easy transition where it'll be embraced by most nurses. But our data indicated that there are a number of nurses that are not that warm and fuzzy about this new addition to the team.
Mm-hmm.
So it doesn't mean that we not do it. It just means that we need to go into these changes eyes wide open and engage nurses early. The ones that will be taking care of patients, the ones that will be executing these strategies, no matter where they're drawn up, needs to be at the table early to make sure there's success. So we looked at LPNs, we looked at former nurses that resigned from the profession. We looked at retired nurses. We looked at what positions do nurses feel would have the biggest influence on their workload, and the number one role was CNAs and patient care techs. So we looked at all those different pieces, in addition to understanding what meaningful professional development looks like. And one glaring divide is leaders feel that the programs that they offer are value added to nurses, where nurses really, where they feel that nurses really love their programs. Nurses are saying not so much. So those are all the things that we're able to uncover with the study. We did get a lot of qualitative data as well that we're sorting through. But it was good to be able to reveal those results of the study to get organizations thinking differently about how to implement change, because we also saw that under the question, regarding change, it was almost split up in a third and a third and a third, where the question was, do you feel that there's a readiness for change, particularly as it relates to care delivery models? And there's a third that said not necessarily, another third that said that was very neutral, and another third that said I'm not willing to change. So those are all important things to walk into when we're executing and developing and drawing up strategies to address the innovations that we're looking for on how we deliver care particularly in the acute care setting.
If I could pick up on that readiness, if you will. And first of all, I love when you use the term think differently. That's what we're all about. So when I hear this readiness, I don't hear a third ready to embrace it with open arms. Count me in. I didn't hear that third. Did I?
Yeah. Well, and that's the thing, because at the base of that, you have so much change and volatility and instability. How do you, as a leader, how do you implement change with folks that you don't believe will be a part of your team?
Right.
Right. So those are all the things that's all the noise in that data. There is a lot of volatility that, when you think about who we're asking these questions of, and when as leaders, you look at the team that you are working with to implement these changes, you have to wonder if they're agency nurses, per diem,
travelers,
travelers, are they going to be the ones that are going to be there to implement these changes at the end of the day? And unfortunately, the answer to that question, the theme there would be no.
Mm-hmm. Yeah, so I want to kind of go back to the buckets you're talking about, former nurses, retired nurses, and then you've got the CNA and the care techs. And it was very interesting that...
And don't forget the LPNs.
And the LPNs, right.
Mm-hmm.
The people that have probably the biggest change or the biggest opportunity to create successful change would be somebody other than the actual RN. Is that true too?
Wow.
Well, so I start with the fact that the largest workforce are your nurses, right? And particularly in the acute care setting. So we start with that. There is a process to change, and I don't think we deal enough with all the different elements of change.
Right.
if you think about the Heath brothers and Switch and that framework, it's really about how you have the elephant, the path, and the rider. And the biggest element in those three is the elephant, which is the emotion. And we don't deal with that, right? We think that we can appeal to intellects, and people will say, oh yeah, you showed me the study, I'm going to do it. So it's all about who's developing the plan. And what we also always say is that you have to have nurses that will be executing the plan, involved in developing the plan. And you have in the middle the group that will be funding and supporting the plan, right? That's your CFO, your COO, and your CEO. And then on the end, you have the folks that will be executing and responsible for implementing the plan. And those are your nurses. And for the most part, no matter which way you look at it, you have to say that nurses have to be involved in every step. So I do believe that there is work that happens behind the scenes with leaders and C-suite executives. And I've been there with exploring all the possibilities, but you have to make sure that you get nurses involved early. And that was a key takeaway with the results of this study.
Right, right. How do you create the psychological safety and trust for the people you're trying to create that emotional change?
Yeah, that's a big one, especially since one of the themes that we did get from the think tank work is that right on the heels of the tail end of the pandemic, nurses had a sense of betrayal. It had not been dealt with, especially when they feel that their safety was compromised in many ways.
Right.
And you do need psychological safety to create fertile ground for innovation. So I do think that there are a number of things to do there to make sure that there is an acceptance of change. And that is, as I mentioned earlier, getting nurses involved early. That's one. But two, we need to make sure we do our best to make sure nurses do feel safe psychologically and emotionally.
Mm-hmm.
And I always point out emotional safety because it's different from psychological safety. Because we've been groomed and conditioned over the years to grin and bear it.
We have.
Any show of questioning or going against the grain or asking questions or even showing anything outside of the positive emotions when there's been so much emotional investment in implementing change, that's frowned upon. So that's where the frustrations come out after the shift outside of the workplace. If you look at what's gaining steam right now, and this is where I'm going to go a little bit outside of the building where care is delivered, you have certain folks that are gaining some traction with nurses with comedy shows around the frustrations with administration. Cruises, where it's mostly about, of course, enjoying each other and engaging in well-being, but there's an undercurrent of dissatisfaction with the current system that's starting to gain steam with folks that are having these forums, social media, and all that to say, hey, what do you think about Joint Commission? What do you think about these things? So there is that undercurrent of dissatisfaction that we have to deal with. That is at the root of a lot of what gets in the way of change. And we don't deal with that enough because we just feel that as long as we have them and they've clocked in, to a certain degree, they have to play ball. And nurses are saying, no, I don't.
Yeah, Sheila's got a great comment here. It made it clear that healthcare facilities were willing to place nurses in high-risk situations and expected them not to object.
Yeah, and that's so. We heard a lot of that feedback during the pandemic. It was especially when it came to PPE, right? That was a biggie. Where for years, sorry about that. If you heard the noise outside, I have a window open. For years, we've been told and in some cases, we've been written up where if nurses have PPE that they didn't discard right away. I was an OR nurse, and whenever the Joint Commission was coming in the building, if an anesthesiologist was walking around with a mask draped around his neck and not tossing it after his first use, that is frowned upon, that is
Of
dealt with,
course.
even staff. And then you get to the pandemic and it's like, oh yeah, you can use these 4 or 5 times over.
Right.
That didn't play well. And there
No,
was
the rules
for
changed.
nurses to complain and object to these policies that were so contrary to what we've been taught and trained to understand over the years. So that is a betrayal that still exists that's out there. And we also hear that nurses are feeling that they're not really well respected either. So those all collide in this place that we're in emotionally, particularly as it relates to nurses and nurse leaders.
Right. Yeah.
Right. And Sheila goes on to say that nurses' families started to realize what was going on. But I have a question for you. Are nurses the mortar that holds the bricks together?
Oh,
you talked about going beyond where care is delivered. Well, that's the brick and mortar.
Oh yeah. Oh yeah.
We are the mortar, aren't we?
Oh, totally. The mortar, the glue, the
building.
every element that holds pieces together, it is us. And I think that's what needs to be realized more and more and understood more and more, because I continue to push that. As much as we're the most trusted, we have to get to the point where we're the most respected, or as respected.
Exactly.
As folks that are higher up in the social hierarchy in healthcare, right? Like physicians and administrators and folks that supposedly bring in the dollars, because I also say that nurses bring in dollars too. It's just not well demonstrated right now because of our algorithms and methodologies. So absolutely. Without nurses, think about who's in the building at the end of the day, 24/7, when folks are going home. It's nurses. But we have to make sure people see nurses, going back to the respect piece, particularly as it plays to the public. We're not just there to hold hands and do help with ADLs. We do research. We are engaging in science. We're doing all those things. We're making decisions. We're writing prescriptions. We need to get the public to see us beyond just being there to hold things together.
Right, to hold a hand and wipe a brow. Exactly.
Totally.
Exactly.
I totally think that. I also think there's an opportunity. Just, my dad was recently in the hospital. I think there's a big opportunity, and I saw this, just that nurses don't have an opportunity to during the day to actually unload some of the frustration they have. So they're carrying it from patient to patient to patient, right? It's just a constant thing all day, and I know my dad's a heavy button pusher, so it's just kind of like trying to do as much as you can to help him. But, when you look at, the nurses that are coming in, they're also locum tenens, that I think also creates some issues for the nurses that are retained in systems, is, being very in that system too. I think there's just so many things to think about. How can we help them unload in a safe environment? If they're having a bad day, have a place where they can have a bad day too.
Right.
But also, I think educating patients, and I told my dad this all the time, what, you think they're supposed to come right away, but Dad, they've got 10 people they got to see.
Who are all pushing the button at exactly the same
everybody's
time.
pushing the same button, and it's going off at the same time. I said, I know it's not easy, it's not patient, but you're right. I don't think patients really understand what our nurse is going through. Nobody really sees that side of it, because the expectation is, like you said, we're here to wipe the brow and hold the hand, but you're doing so much more than that.
Yeah.
Let me, if I might, take us then to that question about the ANA Healthy Nation program, which has been a resounding success. People have really jumped on board. They have embraced it. It evolved with a mission to improve the nation's health one nurse at a time, which is an overwhelming goal. It's wonderful. Tell us how the current environment, based upon what you just said about psychological safety and emotions and more, and workforce issues, contribute to or detract from this mission.
Yeah, that's a great question. So I'll start with why we created, and this was more the credit to my predecessors, who had their eye on the ball very early that nurses were not in a good place. We saw a lot of data that indicated that nurses were one of the most unhealthiest professions in the country. We're going to say the US because that's where our data stops. I dare to say that it extends beyond.
Mm-hmm.
Nevertheless, there was indication that nurses were unhealthy as it relates to their eating habits, sleeping habits, quality of life, physical activity, all those different elements that requires us to be well. So we decided that I say we, but because I'm a part of the team now, but in 2017, there was a decision that was made that we had to create this program to support nurses' overall well-being, and not just address well-being from a standpoint of physical activity, but beyond that.
Mm-hmm.
So Healthy Nurse, Healthy Nation is really about how we can comprehensively understand well-being in nurses, and to create a program where nurses are supporting nurses in being well. Now we take that. We have our tagline of improve the nation's health one nurse at a time. Is daunting for sure, but it starts with us. We are role models to the communities that we serve. So we believe that if we can get nurses to be healthy, all 4.4 million of us, we can certainly turn the tide for the rest of the country and probably for the world. So that's the pretty much the premise behind Healthy Nurse, Healthy Nation. It's a free program. And as much as I've talked about nurses, it's open to everyone. Anyone can be a part of Healthy Nurse, Healthy Nation. We have a lot of non-nurses there too. And pardon me, I'm just trying to put people in the bucket, but they all have value as well. So we do have this program available. It starts with you doing a heat map survey to indicate where you are. And then it gives you an evaluation compared to your peers. And that sets your action plan on how you can continue to engage in activities and things to be well. We created a 6th domain for mental health because we saw enough with the pandemic. And it's not like we haven't seen that this is something that we had to address, but mental health was enveloped under quality of life. So we decided last year to extract that as its own separate domain. And we partner with the Wellbeing Initiative, which is another ANA program that was erected during the pandemic. So that nurses can really use tools to take care of themselves and provide them support for their mental health. So overall well-being is pretty much what we try to encourage. And we also say that nurses' well-being is a team sport. It's not an individual activity. You need everyone around you to help you continue to stay well, because we see the data also with peer support programs and what that does. Right. So that's the premise around. We have a great burgeoning community of people that talk about different things on how they stay well. If you work night shift, what do your eating habits look like? If you work weekends, 12-hour, 14-hour shifts, you should snack during the day and drink water. We have challenges that we do as well for folks to put them on a path to being well. So it's a great program, and I encourage everyone to sign up. HNHN.org is the website.
What's the website one more time?
HNHN.org.
Thank you.
Sure.
And I don't know if you've ever really thought about it, but that might be a great initiative to submit to the ShareCare Awards.
Okay.
That would really, if you have a video that describes that, especially when it embraces so many people beyond nursing, you're encouraging people to own their health, to own it.
Absolutely.
And I love that. You might consider that, Katie.
Yep.
I will definitely take that under advisement and share with my team. Thank you for sharing.
Yeah, that would really be a really good thing to have happen. I would love to see it personally.
Oh, awesome.
So what role does the environment play in recruitment and retention? Is it more than just culture? Because for years, we've been hearing about culture, and over the series of these calls, we've been hearing through our interviews that culture has to align, your personal culture has to align with corporate culture in order to make a fit, or no one's going to stay. How does that environment impact recruitment and retention?
It does. And I'll break it down even further. I say values, right? My personal values, organizational values. I think more now than ever, with in being in such a turbulent world with so many things that we thought were done deals that doesn't require a lot of debate because of the fact that we're all intellectuals and we advance our thinking as time evolves over centuries. It feels like we've taken a step back over the last couple of years, right? Where certain agencies that were long trusted are no longer trusted. Science is being debated as being witchcraft and things like that, right?
Yeah.
And then you have the tribalism that's happening in politics. It's now in healthcare, very much so. You saw that with vaccines, right? And
in
masks. So that's where during one of the WHO sessions that I listened to during the pandemic to get some insight on what was happening in the world, there was a lot of talk about moral leadership. And moral leadership, even though there was an impression at one point that it was assumed that if you're a leader, you have strong morals and you care about people, we've learned that not necessarily so.
Yeah. Nope.
So so what cuts across all these things that divide us are what we believe in and our morals. You can connect with someone across the aisle that has different political beliefs, that probably does not believe in vaccines or masking, but you probably share the same values.
Mm-hmm.
And I do think it comes down to that. I think
it does.
If we understand our own value set, right, and align that with the value set of the places that we work, and when we are seeking employment, we ask specific questions about how those values are demonstrated.
Mm-hmm.
And also by leadership, I think that gets us to that culture piece.
Right.
And the other thing, when you do settle on your values, which could change over time,
Right.
You should wear that on your sleeve. People need to know that you believe in integrity, you believe in family, you believe in respect. You know, some of those things.
Right.
Say it, because when you say it, that's how you're also held accountable. So
Right.
I
Exactly.
think those are the things that can help cut through a lot of what we're seeing in terms of culture. But we also know that leaders have permitted certain things over the years because it's tiring to deal with bad behavior
Right.
and not so positive behavior.
Mm-hmm.
And I'm a strong believer of what you permit, you promote.
Exactly.
And when you
I
look,
was just going to say that. What you accept is what you get.
yeah, so when you look
Right.
the other way on things, I was listening to recently to Nixon, Richard Nixon interview after Watergate. And he was talking about the big things and the little things. And he said that, and this was an interview that he did after Watergate, which I'd never seen before, right? Because I thought that after Watergate, he just went into obscurity and no one
So did
talked
I.
really.
Okay.
So that I was intrigued by that. So he did an interview and he said one of his lessons from that experience is that as much as he focused too much on the big things and not enough on the little things.
Mm. Yep.
And little things, if you don't pay attention to them,
Mm-hmm.
become things.
Become big things. They
Yep.
escalate.
Yep.
So he said that, and when the little things become big things, then there's this guilt that you feel, and then the decisions that you make to deal with those little things that became big things are not necessarily the best decisions, because you're working from a not so positive place to deal with that
Mm-hmm.
issue. So that's how we make those decisions that go against our values and our morals, because like, oh my goodness, I got to fix this now. It grew, and it's now at this point I have to deal with it, and you deal with it the wrong way. So that's why the little things, right? Like the people showing up late, people not necessarily displaying standards of excellence, right, in small ways.
Mm-hmm.
Those
Mm-hmm.
things, and that's when this culture thing becomes a major glob that
Mm-hmm.
you can't deal with anymore.
No, it
Because-
metastasizes, Katie.
Absolutely.
Totally.
Right. Right. Well, we are getting close to the end here, but I want to thank you for today because I think you're amazing. We could go on for hours. That's what we tell everybody. We could talk for hours. And so we want to talk about what's next. You know, we have a collaborative book coming by our interviews. We have a white paper that we're getting ready to write. We want to do a banner for Nurses Month for our series by the two of us. We want everybody to watch for our post in the interim. We invite you to explore this learning system that we just launched. We want to take advantage of these offerings. We want to help transform your career and talk about the things, because you're exactly right, Katie. It is the little things. If we as leaders keep our head down and only focus on the big things, and we don't look up and look around and take a good, gander at what's going on around us, we're going to miss that. So it's time for a close. And I think you've been wonderful, Katie. We want to remind you of the website that she says that you have some resources for, hnhn.org. I want to make sure and get that out there because I think that's very important. And we want to thank everyone for being a part of our journey, for listening to her and getting the stories out. powerful stories. And I want to hand it to you, Sharon, to do a final close.
Sure. And I hope that you too, Katie, will consider contributing to our book. It's only 1,500 to 2,000 words based upon what is near and dear to you.
Okay.
Based upon this concept of owning it, of not band-aiding things, of really taking ownership and being a part of more than just the mortar, being the brick.
I appreciate the
bigger
opportunity.
picture.
Thank you.
Yes.
Yeah, we would love to have you do that. As a matter of fact, we would love to have you write the preface for that book, because I think that everything that you just said today sums up what we have been hearing, and that would be an amazing opportunity.
It really does.
So I too want to go on.
Thank you.
Great.
Well,
that would be awesome. I will connect with you on that.
Yes.
We want to thank you for being with us today. We want to thank all of our viewers who have been so loyal during this series and have contributed so many comments, have given us feedback after the programs, and who really want to learn more and be a part of the solution rather than the problem.
Yes.
So with that in mind, I want to thank all of you for your loyalty, for being with us, and let's bring this to a close. Thank you, Katie.
Thank you.